It's great.
Okay. All right. So, all right. Am I go then, or you guys need to do anything else?
We can see your slides and we can see you, we can hear you. It's all set.
It's
All right.
all sync.
All right. So since it's recording and this might be used for other purposes, I'll just say again, my name is Heather Schultz, and I am honored to be here. Thank you, Jeff. Jeff and I have worked together for so long, and Jeff, I've learned so much from you, and it feels so good that now here I am being able to give back a little bit. So thank you for giving me the opportunity and teaching me all these years. So my talk that I was asked to give is about low risk, low to intermediate favorable risk prostate cancer and management of that, which can be active surveillance, but then also focal therapy. I have no disclosures, so I have no financial interests other than my paycheck from UNC. So my objectives for you guys today will be to define who meets criteria for active surveillance, list out some of those protocols, which can be very varied, and then also name some focal treatments that are available. But I do have to give you guys the caveat that I know about cryotherapy. I don't know about the other focal therapies since UNC does cryo only, but I'll name out the other ones and give you our experience with cryo. So you guys already know this, but prostate cancer is actually pretty common. Oh my gosh, I'm so sorry. I think my kids are screaming and I don't even know if that's being recorded, but I think one of the guinea pigs got out and our dog is chasing it. So anyway, all right, the show must go on. So as you guys know, prostate cancer is one of the most common cancers. And so there are a lot of it and there are a lot of options for treatment, but the question is do all prostate cancers need to be treated? And so that answer is actually no, but how do we decide who needs treatment and who does not? So as a clinician, there are 4 things that we always think about when we're trying to help patients in decision-making for this. So it's based on risk stratification, life expectancy. So if you have less than 10 years, maybe you should not have treatment because it could hurt you more than help you. We think about oncologic outcomes versus quality of life, and then patient preferences and what they want for themselves. So how do we risk stratify people further? So there's a few tools that we use. One of them is through the AUA or the American Urologic Association. They use a 3-tier system. Another one is through the NCCN, which is the National Comprehensive Cancer Network, and they use a 6-tier system. But kind of in a nutshell, active surveillance candidates are those who meet criteria for very low or low risk. Now you might be on active surveillance and not meeting this criteria to a T, but this is the strictest criteria that is out there. So if you're a little bit different from this, that's okay. It can be varied. This is just a guide. But basically it is people who have grade group 1, Gleason score 6, clinical stage, so meaning like by rectal exam, did you have a nodule felt or not? So we want them to be T2A or less, so meaning no nodule would be best. PSA density, I don't know if you guys have used this or it's been talked about with you guys, but PSA density is something we use where we take the PSA, we divide it by the size of the prostate and come up with this number. And if it's less than 0.15, we all feel a little bit better about someone going on active surveillance because it means maybe some of that PSA rise is due to having a bigger prostate. So giving people credit for bigger prostates. We also want to make sure that the core number of cores are positive or less than 3, although this is variable. So just, this is strictest criteria. If you have 4 or 5 or 6 or even 7, it's probably okay. And we don't want any more than half of that core to be full of cancer and PSA less than 10. So then favorable intermediate risk, you guys probably already know this, but that's categorized as grade group 2 or 3+4 prostate cancer. And there are several updated guidelines. The NCCN put one out in 2020 that gave the option for intermediate risk folks to have the option for active surveillance. So this also would be less than 50% of the cores being positive. You want folks to have greater than a 10-year life expectancy, but you do want to consider other things. So PSA density, so calculating that number. If cribriform is in the pathology, which is a histology that is written out on the pathology report that can indicate a higher risk prostate cancer. So we want to be mindful of that. Did folks get an MRI and did it have any funny things on there like extension of disease or extension into seminal vesicles? And then genomic tests, did you have any of those done? And I'm not speaking on that today due to time constraints, but genomic tests can also be incorporated into decision-making as well. Now, favorable intermediate risk has been suggested for active surveillance now in practice for about the last 5 to 6 years. So it is catching on and is an option. So what do the studies say? So unfortunately, there are no US randomized trials that compare active surveillance to prostatectomy, to watchful waiting and things like that. But luckily, our friends across the pond do have some studies. So a few of them here that I've listed out. The Scandinavian trial is actually pretty old, and that's pre-PSA. But what they looked at was people who had their prostates removed and then compared them to people who were on watchful waiting. And they did favor prostatectomy over watching the prostate cancer. But keep in mind, again, that these are probably people who presented with higher risk disease. They found that the median life expectancy was better for people who had prostatectomy by 2.9 years. So there's that. But then there's the pivot trial. So that's the next one down. And they compared prostatectomy to watchful waiting. They, interestingly, did not find improvement in disease-specific mortality. So that means death. So people they did find that they progressed and maybe became metastatic, but it didn't equal mortality. So that's interesting. And then the PROTECT-T study, this was started in 1999. These were randomized men. So they're randomized to either active surveillance, prostatectomy, or radiation. And they found that at 10 years, when they followed people, because they followed them for a long time, that there was no difference in prostate cancer mortality between the people who watched and the people who had treatment. And again, they did find that there was some progression of disease, but again, that did not equal death. And then hot off the press, they came out with their 15-year outcomes data. Still the same findings. Prostate cancer specific mortality was still low. And amazingly, 98% of the men who enrolled initially were still available to collect the data. So it's some pretty cool results for us. So basically, bottom line is that, active surveillance is certainly a reasonable option. The natural history is very slow, and most prostate cancers do not lead to death, but can lead to some morbidity. But what did the guidelines say? So these are the guidelines that came from the AUA and ASTRO and recently updated and published in 2022. And basically they say anyone who has low risk prostate cancer, so Gleason 6, should be recommended to have active surveillance. We should not be treating those cancers. And the next line down, people who have a limited life expectancy, so less than 10 years, maybe should undergo watchful waiting and not talk about any sort of treatment. And then interestingly, in these guidelines, they say that people with favorable intermediate risk, so that's again, Gleason 3+4, disease PSA less than 10, an option is to consider active surveillance, but then also talk to folks about radiation and prostate removal as well. So again, bottom line, active surveillance is certainly reasonable for select patients. I have patients all the time that ask me about adjuvant therapies that they can do, things that they can take to kind of help prevent progression of disease or just prostate cancer in general. So there are some studies that looked at this. You may have heard of the medication finasteride or dutasteride. Those are given for men who have enlarged prostate. And there was a study, the PCPT, which looked at finasteride, and it did show that it decreased prostate cancer risk by about 25%. They found about the same for dutasteride as well. So this seemed like, really great news. But then, unfortunately, the FDA Oncologic Advisory Committee got a hold of it, and they're like, wait a minute. They looked through it, and they're like, some people, very few amount, were found to have a slight increased risk. So men who are on these drugs, a slight increased risk for development of high-risk prostate cancer. So then they slapped a warning on it that said, nope, you cannot use it for chemo prevention. And now you got to tell all your guys that they could be at risk for developing a high-risk prostate cancer. So that's part of my discussion with folks about finasteride and dutasteride, but that risk is very low. And men who are having a good outcome from it, we don't tell them to come off, but we can't tell them to take it to prevent prostate cancer. And there are many thought leaders out there that are asking the FDA to relook at this data and take that warning off because that risk is so low and it's really scaring men. Okay, what about other things? So I don't know if you guys have ever been part of any of these trials, but the selenium or vitamin E cancer preventative trial or the SELECT trial, UNC was a site for this. Unfortunately, there is no significant reduction in rates in prostate cancer. This was big. There was a lot of men. 35,000 men who had low-risk prostate cancer were randomized to these different regimens in combination. But unfortunately, we cannot say. I do have to say that I have a patient who was part of this trial a long time ago. And he does not have prostate cancer, and he swears by his selenium, and he's still on it, and he still doesn't have prostate cancer. So I was like, okay, fine. The studies don't support it, but hey, if you want to stay on your selenium, I guess it's not hurting you. So how about diet? So this was a study done. It was the meals study, men's eating and living study. It was a multi-center phase 3 clinical trial, and it randomized men to increase vegetable consumption. The eligibility criteria for this was that you had to be on active surveillance. There was about 478 men that did sign up, but unfortunately, we can't tell men to eat more vegetables, but I will tell you to eat more vegetables because we do have studies that say Mediterranean diet is healthy, but this one specifically could not say that eating vegetables was helpful for reducing prostate cancer progression. All right, so how do we monitor active surveillance? So there are lots of ways to do this. There are no strict criteria for this. It can be very much based on the culture and your institution. So just take that and take this with a grain of salt, but this is kind of the average of the averages. And so basically for active surveillance, it's recommended you get PSAs every 3 to 6 months, perhaps consider a confirmatory biopsy, maybe even with MRI guidance. So you get an MRI, and if it sees a target, then you biopsy that area. And then include systematics, which I'll talk a little bit more about in the next slides. So those other samples that are taken not just from the target, but from the other areas of the prostate to make sure you get a good sampling. Perhaps repeating these biopsies every 1 to 3 years. PSA kinetics, as you guys know, PSA is one way to tell how things are, but is not perfect. And then the role of molecular biomarkers is uncertain in the setting for surveillance. At UNC, what we do is we do a confirmatory biopsy at about 6 months, and then we do another one at 12, 18, 24 months, and then every 3 years. And then we stop after age 75. But again, it could vary. It could depend on MRI imaging. And we do MRI fusion biopsies if we can in our surveillance protocol. So I don't know if you guys have ever said this to your clinicians as far as, if you're doing active surveillance or if you did and then were treated, but have you ever said, like, can I get an MRI? And if it doesn't show any lesions, can I skip my biopsy? I mean, I have folks that ask me that, all the time. But unfortunately, the negative predictive values, so meaning like the MRI, the likelihood that MRI shows nothing there, and that is correct, it can vary. And the reason why these numbers are so different is because the radiologist, it's very dependent on the expertise of the radiologist, how many MRIs they're reading a day. Are they reading 5? Are they reading 50? And then it also can depend on the type of MRI machine that you have, the quality of it, and the magnet. So it's great to have a 3T magnet if you can. There's also, interestingly, some data out of Rochester that says cribiform. So remember, that is that histology on the pathology that can be more aggressive, is actually maybe a bit more difficult to see on MRI. So we just don't have enough data to say that we can just use MRI alone and skip biopsy. Is it being done? It is. Have I done it before for a couple of people that had bad outcomes with their biopsy? Yes. So there is some wiggle room, but just so you know, the data doesn't exactly support it. All right, and what do the guidelines say? So they say that clinicians should utilize multiparametric MRI when they can to help with risk stratification, but it should not replace periodic biopsy. So I'm sorry, we still have to biopsy. And then MRI fusion biopsy. I don't know how many of you guys have had MRI fusion biopsy before, but there have been a lot of studies to support that fusion biopsies have shown that there's a lower rate of upgrading on final pass, so meaning that the clinically significant cancer is being found, which is helpful. It also can help find anterior tumors, which are on the side of the prostate that we don't typically biopsy, and maybe even in other areas like the transition zone or central zone. And it's more sensitive to high-risk disease. So that means like Gleason 8, 9, 10. But MRI fusion is also not perfect. I've had patients ask me before too, if you can just do the biopsy of the target that's positive on the MRI. And unfortunately, we have insufficient data that says we are there and we can do that yet. So when you get biopsies, it's still recommended that you get samples from that target that might be positive, but then also the systematic, so the random samples in the different areas. So just not quite there. All right, so when to treat? So of course, if the grade group or the Gleason grade goes up, so it's 8, 9, 10, or Gleason 4+3. If the number of cores goes up, if PSA is more than 10, because that can put you in a different risk category. Maybe patients are anxious or fearful of their disease. They're losing sleep at night. It's affecting their day-to-day. You know, that's a reason to treat too. Or maybe patients are scared of their repeat biopsy and can't have it under anesthesia or something. So all reasons to proceed with treatment. All right, so I'm just going to switch gears here. And for the sake of time, I'm sorry I'm going so fast, but just want to respect everybody's time. I want to give you this case and have you guys think about this. So what if this 63-year-old man comes in and he's got this PSA that's high. He had this MRI image. It showed an area that looked abnormal and he had a targeted biopsy. So he had this targeted biopsy and it shows, so in that area where it says target number 1 up here, that's that area that looked abnormal. It showed prostate cancer and it showed Gleason 3+4. Or intermediate risk disease, favorable. All the other samples were negative. And he really doesn't want definitive therapy. He's really not comfortable with the idea of active surveillance. So what could be offered to him, or what, if this was you, like what could be a treatment for you? This might be a good space for focal treatment. So basically the framework that we like to use for focal treatment is that you treat this very specific area and it helps preserve functional outcomes. So erectile function, urinary control. So it's treating this index lesion, which is just fascinating to me because there's some studies coming out that support that maybe there's this index lesion that is the higher risk disease that you can treat to help control. Maybe not take care of all disease, but maybe take care of the most worrisome disease. As we understand prostate cancer right now is that it's multifocal, it can be anywhere. But what if there are these index lesions that you can treat? But just remember, focal therapy is considered exploratory right now. It's not recommended for high-risk disease, and active surveillance is still the preferred modality for low-risk disease. So maybe this is like a good space for folks who have intermediate-risk disease. But the data supporting its effectiveness and safety is still, the jury's still out on that. So let's talk about the guidelines. So the guidelines say that there are lack of studies comparing it to active surveillance, surgery, and radiation. So it should really only be offered in clinical trials. I'll be very honest. We offer cryotherapy. It is not in the setting of a clinical trial, but we really try to educate our patients about the risks and benefits of it. So focal treatments, what types of different energies are available out there? This is a list that I know of. And the one specifically I'll be talking about is cryotherapy. And there was someone who had one of these other that I don't know much about any of these. We actually might have a trial opening for focal laser ablation. But for the sake of my knowledge, I'll be specifically talking about our experience of cryotherapy. And how we chose cryotherapy was basically, of course, it's all about money. And HIFU at the time, it was in 2018 we started our program. under the direction of Dr. Mark Bierlin here. HIFU is not FDA approved for prostate cancer treatment, so we couldn't use that. And insurance was reimbursing cryotherapy. So that's what we did to start. So this picture just kind of shows you the different ways that they can do their focal therapy. They can do hockey stick, hemiablation, and then we at UNC do targeted, focused on the target lesion that is positive. So the goals of focal therapy is to control cancer. So maybe not cure it, but control it, and help people's quality of life, all in the same kind of setting. So basically, the idea is to treat the clinically significant prostate cancer. And I have to give credit because I didn't do it on my slide here, but I need to give credit to Dr. Mark Bierlin. This is actually his slide that he uses. Okay, so let me talk a little bit about the UNC experience in cryotherapy. And I'm going to run through this pretty quickly. But who do we treat? So this is based off criteria that is primarily from NYU, because they have a very robust ablative program there. And that is where Dr. Mark Bierlin was trained, and his mentor, Dr. Samir Taneja, is there. So this is a lot of their kind of protocols, but basically a high quality MRI, 3T magnet is preferred, and a target being seen on that MRI. PSA, we like it to be less than 10. And then the Gleason score, ideally for us, it would be these people in this intermediate risk group. No extracapsular extension, because then that would upgrade the stage. Apical lesions, so those are lesions that are found at the bottom of the prostate. They're actually very hard to treat. So, so we prefer that if a lesion is seen there, that maybe we don't treat them with focal therapy, because that'd be pretty hard to treat that one. And then we don't want the lesion to be any bigger than 20 millimeters. If so, it just makes it more difficult to treat thoroughly. So this is kind of a rundown here of what we do. It's kind of a very simplistic rundown of our workflow. So this picture here in the center is showing you the cryo probe that's inserted. And this is a live monitor that they see live while they're doing their cryotherapy. And it gives different views of it. The target is seen on the MRI and is mapped out. So this is a picture of the prostate here. And then this is where they want to target their thermal ablation, their ice ball. You can see that it kind of extends over the margins, which is what they want a little bit, because you want to make sure that you get everything. Dr. Bierlin has done about 50 patients so far with this. And oops, sorry. And then this is actually showing the grid that he uses. So the little needles go inside there. It involves freezing, and it cuts off the blood supply to the cancer cells. And then they use gases. They use argon gases that pass through those needles, and it's exchanged for helium. And so that causes like this freezing and warming cycle. And then that dead tissue is just like reabsorbed by the body and thaws, which is kind of cool. So you don't have to take anything out. They also use a catheter when they're doing this, and it's a warming catheter in the urethra, and that's to keep the urethra from freezing, and then also helps preserve and prevent strictures, and helps sphincter preservation as well. People who have lesions that are near the urethra are not the best candidates for cryotherapy because they're at risk of urinary leakage, and you just can't freeze very well around there. And then these are the different examples of the grids that can be used. This flat grid is more stable. It's better for a planned intervention like cryotherapy, which is the grid that we use. This is a nail grid. It's more flexible. It's better for angles. And it can be used for transperineal biopsies, but also ablation too. So, and then what are the risks of focal therapy? People can go in retention where they can't pee. They can have blood in their urine. They can have soreness and tenderness in that area in between your rectum and your scrotum, because that's the area that they're kind of targeting where they go. You can also get infections and swelling of the penis and the scrotum. And then another odd thing is like this burning sensation in the bladder. We're not really sure why, but maybe the nerves are affected, and it seems to be transient. Like it happens for like 4 weeks and then it just like goes away. People can have some urgency, frequency. Leakage of urine is very rare. Fistulas, or where there's a connection between the urethra and other parts of the body, like the rectum, that's very rare. That's more with salvage cryo, where the whole gland is frozen, and urethral strictures are pretty rare. Follow-up, this is based on the NYU criteria for follow-up, but basically people have this done outpatient. They go home the same day. Their catheter's out in about 3 days, but sometimes it can be a little longer depending on what their status was beforehand. PSA, interestingly, is not helpful at all. We have found in watching patients who have had cryotherapy, but we still get it. That's all we got. So we do rely heavily on MRI imaging, and we do it at 6 months, 2 years. And then if targets are seen on that MRI, we do targeted biopsies, and that's how we know how things are going. So reasons why it doesn't work. Sometimes it's inadequate detection. It just wasn't visualized or localized appropriately. Or maybe the MRI missed things, or maybe there was undersampling to begin with, or the target area was just undertreated, or maybe the margin was not adequately frozen. So take-home message here is that focal therapy can leave some cancer untreated. Additional treatments might be needed, but it can preserve function and quality of life and do something if you want to do something and not just watch. But it does require close monitoring. We need more long-term outcomes data on it, and just proceed with caution. We need more clinical trials on that. So I want to thank you guys so much for having me. I am happy to answer any questions. I'll leave you some links here to some great resources that we use for our prostate cancer patients. Jeff, you probably do too, and some videos as well about treatment from the FinPath group. So with that, any questions?
Yes.
Yeah, how about going back to 2 slides, you had the little grid, that was very interesting. So there were insert needles in every every box in that grid. Is that it?
They don't do it in all of them. Dr. Barron will use like 3 or 4. It kind of depends on the prostate size as well, and where the target is and how many targets they're going for. But they don't do it in every, they don't put a needle in every hole.
Okay, okay.
So they map it, and then they
Yeah.
figure out exactly where they want to go, depending on where they saw the MRI, everything.
Yeah, I don't, let's see, maybe you can see it, like, see on this one, see how they have needles in just a few of them? That's them mapping it out.
And remember too, when they put that in there, it's not just gonna freeze a little dot, it's gonna freeze that area around where that pearl goes a little bit.
Okay.
So, but it's very focused and very mapped.
Okay.
But it's cool.
I have 2 questions, okay? First, I want to make sure I understood your biopsy regimen for someone who is on active surveillance, because did I see something doing biopsies in less than a year's time? Because I think I was part of an active surveillance at Johns Hopkins, and they required a biopsy just annually, okay? So and then the other thing you said, let's say from an MRI, you identify a spot that looks suspicious, and you take a biopsy from there, but you don't just take that one biopsy, you take the standard regimen, which I'm guessing, is it still 12 these days?
Yep, it's still 12.
Those
Yes, yeah, okay. So, did I understand correctly that you're doing biopsies more frequently than annually?
Only the first one. So, sorry if I didn't clarify this good enough, but when someone is first diagnosed, we do something called a confirmatory biopsy and a repeat MRI. So that's done at 6 months. If a target is seen, then we biopsy that target plus the regular systematics, the 12 samples. But then that's it. If that pathology comes back fine, then we go to the annual. But that's called a confirmatory biopsy, just to make sure that they truly do have low risk or favorable intermediate risk disease.
And most active surveillance programs have the confirmatory biopsy thing built into it. That's part of the program. Is so you come in with your information and what you have, and then they do this confirmatory biopsy at 6 months.
All right, well, I waited a year when I was originally diagnosed. And then I enrolled in Hopkins active surveillance program, but they kicked me out because I went up, you know, they found 50%. Even though my PSA was never got above 3, I had low PSA. They said, "You're out of here."
It's changed a lot over time, and it used to be very tight, very rigid. And there's a lot of wiggle room in most of the programs. You know, like she said, Heather's telling you the very strictest criteria somewhat, but there's wiggle room in there, and all of the programs have wiggle room. And as we move along and learn more, there's more wiggle room, you know, in a lot of our programs. I know we have a big active surveillance program at North Shore, and there's a lot of wiggle room.
But it was interesting to see most of the criteria. Now, I did this in 2007, so that was 16 years ago. Still is the same. PSA less than 10, and I forgot what the others were, but still, you know, pretty much not too much different than it was years ago. Because I imagine, you know, people borrow from others what they do, and like you say, they do relax it.
Because they're learning more and doing better.
Yeah,
definitely, and they become more comfortable with it. So I know 2 of the others are in active surveillance as well. And so you had talked a little bit about your particular circumstances and where you're at in things as well. And Heather, we were doing the really strict timeline criteria for you. So we're here anyway. So, but if you need to stop at any time, it's fine.
I think they got control of the dog, and I'm not sure if the guinea pig's still alive, but honestly, I'd be okay if it wasn't. So, you know, whatever.
If you're okay, we'll go a few more minutes. But I know Ned and Ted, you both had some. Ted, did you want to talk a little bit, or Ned, whichever wants to start?
I guess I mean, I'm very similar in all this. I'm at 50% right now. It's all Gleason 6, but 50%. And I didn't do the last biopsy I did was not transrectal, it was transperineal, which came up with, which increased the number of, well, we found more cores that were positive. We also did more cores, but everything else was pretty clear on mine. It was right within most of those guidelines. I think the main thing that I just had was approaching that 50% number. I'm doing biopsies. We're trying to go to once every 2 years, depending on my PSA right now. So that's kind of what I'm hoping. I don't love them.
Yeah. We have a lot of patients that have more than 50% of cores positive with Gleason 6, and we're watching them. We're comfortable with it. They are, and they're doing really well. You know, that criteria of the 50% is the strictest criteria. And I mean, we're watching intermediate risk disease now. So, you know, 10 cores of Gleason 6 maybe isn't such a big deal anymore.
Yeah.
I think they're getting more and more comfortable with more of 3+3s, more 6s, more, you know, I think all of that is really moving along. And then 2, we have the intermediate to 3+4s and stuff. And I think we're getting more and more comfortable with it. And as we do and see patients doing well, knowing that, well, they can move on to something else if and when they want, I think you'll see more and more of all of that. So I think they're going to watch you carefully, and you'll be able to make some decisions at each juncture, and you're still doing well.
Yep.
And I know Ned was just sharing his good news. I think he was 3 out of 12 of his cores, and they were all still 3+3. So looking really good still. Dr. Catalone was kind of talking to him about moving on, and then he had some really good confirmatory things to say. He doesn't need to do that right now. So that was really good news for you, Ned, with your active surveillance.
Yeah, but I feel really powerless about the whole thing, it overwhelms me emotionally and all that. And I just wonder if I should get a different urologist. I don't know.
Well, can I say something? If Catalona, he's the big surgery guy, right? He studied under Walsh and he does the full open. If he's giving you a green light, I mean, that's, I don't know how much better you're gonna get. And by the way, may I ask your age?
73.
Okay.
So Ned, and I think you bring up a really good point that, it can be a trepidatious path. It can be kind of nerve wracking being in active surveillance, knowing that there is a cancer there and things are going on. And I think that that is not an unusual thing for men in active surveillance. And as Heather said earlier, sometimes people move on to treatment just because of that. And that's okay in some circumstances. But I know Dr. Catalona, who's very much a proponent of moving forward and doing the surgery, and he has told you now, hey, you're looking good, you can stay on active surveillance. Did that help with your comfort level some, or what's making you trepidation?
He always seems like he's doing it grudgingly. I mean, he's just not very warm, and I know we're not supposed to be friends and all that, but I don't know, he's just all he wants to do is cut.
And so
Exactly.
I really do think that you would do well with a person who is more acclimated and really, really comfortable with active surveillance. So I do think that's something to think about. There's some very strong programs here in Chicago, and there's plenty of people you could see. I mean, even the other guy you saw, he's more comfortable with things like that as well.
Yeah.
And so I think there are people you could see if you really are feeling that way. And I understand why you feel that way, because we've talked about this before, and I think you're on the money with some of the things that you're experiencing, and many of the men from the group have said the same thing to you. So I think there's plenty of people you could switch over to with your active surveillance. And so we would all be very supportive of whatever you decide to do that. But
how do I find them? How do I find those other doctors?
well, it's just deciding. There are very specific, there's active surveillance programs at University of Chicago, at Northwestern, and at North Shore. All of the major institutions have them. So it's just, thinking about what's convenient, where you like to go. They're all excellent programs. It's just where you like to go and getting in a program that is really active surveillance friendly, because they're doing true active surveillance and they're not doing it begrudgingly at all. They're doing it because of the criteria and the evidence says it's the right thing to do. So it just depends on where you want to go. Of the major institutions that do that across the city of Chicago, what'll work and is convenient. And then there's programs at each of those places with urologists who are in charge of those active surveillance programs.
Okay.
So
I know.
go ahead. Ted,
I know that when I was going through it, I was pretty uptight, nervous, concerned, didn't know what the next path was. But I think when I hit the 50% number and I saw these, I got increasingly nervous. And the one thing that we did with my urologist, we ordered a Decipher report. When that came back as all lower risk, then I felt much more comfortable that at least we were going a path that seemed to make sense. So I don't know if that's something to consider either.
Before we continue, I do want to allow Heather to get back to her guinea pig and her family and the dog, because she so graciously gave her time. Heather, you're awesome. It was everything and more that I remembered from AUA and some for the guys. They're very educated, so I like that you kept it. There was a lot of great information, some wonderful visual things for them to see with the cancer and everything. So thank you.
Oh, no, thank you guys. Thank you for having me. This has been great.
All right, have a wonderful evening. Enjoy your family, and thank you for giving us your time and expertise.